and so many giant cells, foreign body. There has to be something, and we just sat and saw. And can you make out that these giant cells have that fungi? This looks like hylohyphomycosis. It was not pigmented. So one of the variant of this pheohyphomycosis is hylo if it is not pigmented. Next. Yeah. This is just to show you that case with Dr. Jairam had sent. So these are the fungal pseudohyphae which are engulfed. Such big ones. So if you see now, and if you have this carry home message, if you have this, yes, I need to look for this, then you will never miss anything. Yes. We'll go on to the next one. Next case. Yeah, you don't know what is that next case, but I'm not just numbered cases. Yeah, we'll go to the PPT first, and then come back here. One or two pictures in the PPT. This was a young lady who underwent laparotomy, and the specimen was sent to us. This is the history I've given. Nothing else. So if you want to ask any other history, now I'll give you. Next. What is this? Only thing that is visible is the lymphoid tissue, right? Next. All these, they don't have their morphology. Only outlines are there, no morphological details. So you can make out, this is an aggregative lymphocyte. Anything that you want to see there? Which will, next. What are all this? Blood vessels? It's a broad term, right? We need to give the name to a blood vessel. There? Yeah? Elastic arteries? Veins? Capillaries. Anything finer than that? Finer than that? Vascular channels? Sinusoids, okay? Sinusoids? Yeah? How are they? Happy? Bloated? They're congested. Yeah. I've given you a terminology, and then first I've told you, I think you need to get the organ next. Yeah? Spleen. Spleen. So lady was operated, I said. Laparotomy done in this specimen cell. It was, say she had repeatedly pain abdomen, and the continuous dragging pain also. Dragging pain and pain abdomen. If you have identified this as spleen, dragging pain, pain abdomen. What could be the reason? Splenomegaly. That heavy mass, it was almost 2 kgs, I think. It was dragging pain. Then pain abdomen, severe burst of pain abdomen. What can happen? What can happen to that spleen which is so big congested? Infarct. That gives rise to acute pain abdomen. So it need not be therapeutic, but anyway, to relieve her pain, probably the surgery was done. Next. This is clear? What do you find here in this lymphoid aggregate? Arteriole, right? That is the one which tells you it is spleen. Yes, next. We'll go back to the images. You saw that architecture? What was that architecture you saw? Alveolar? We have landed with a high-powered view. Cells are visible? Yeah?
Storage.
No, I want you to describe the cells. Let it be anything. How are the cells here? The large cells. Then, nucleus? Eccentric. Sometimes it is there in the center as well. Some of them have two nuclei. Yes. Neoplastic cells? Neoplastic? No. Any other cell? Do they resemble any other cell? Somebody told me once. They call this any other cell which looks like this? Forget about the spleen. Foamy histiocytes, you're calling this as foamy? Foamy? Vegetable cells, okay. Any other cell? Large cell? Abundant eosinophilic cytoplasm? Yeah? Oncocyte has eosinophilic granular cytoplasm. Not so big. Any other cell? No, somebody told me, that's why I'm asking. I'm telling you, but not in the spleen. They said these cells resemble something. Any cell you search for in a neonate who comes with obstruction, intestinal obstruction? Ganglion cells. Somebody told me they look like ganglion cells. How do you differentiate this from ganglion cells? More eosinophilic cytoplasm then? Nice nucleus with nucleolus. Nucleus with nucleolus will be seen very well in ganglion cells. Yeah. So you are seeing now cells which are very large, as you said, eccentric or centrally placed nucleus. And somebody described this tissue, the cytoplasm, as crumpled tissue paper appearance. So that means it's not vacuolated. No, there are strands of cytoplasm. So then you're directly there. You have hit the diagnosis. Gauchers. So these are Gaucher cells. This is Gauchers. Many of them, many times splenectomy is done for Gauchers. Let us not deal with the disease proper. I'll just go with other cells I want you to identify. We are just at the morphology now. Yeah, I think all this. So what is this area? This is a congestion. Splenic congestion that you are seeing. No, hardly there are few follicles, lymphoid follicles that are left. You can see that some of these cells, when we saw in the first slide, there was no morphological details, but the cells were there. So that is the infarcted zone. This is also partly the cells. Do they have the morphology as the cells I showed you in the previous slide? No. So this is from the infarct area. So we know about the distended fibrocystic cells, the Gaucher cells. I just put a picture of Gaucher because we keep looking at all other famous pathologists and scientists, but hardly I think we see Gaucher. Whereas Landsteiner, yes, day in and out, probably at least twice in a year whenever we conduct June 14th, we look at Landsteiner's pictures. So Gaucher cells, these are, as you said, they have a striated appearance, the cytoplasm, and crumpled tissue paper or wrinkled tissue paper appearance, and these cells are mistaken for another cell in the bone marrow. So that is, in the bone marrow, ceblohistiocytes, pseudogaucher cells, Niemann-Pick cells. Whereas in tissues we know this. And how do we know these are Gaucher cells? Now we go back to the history, we look at. So this patient had come with chronic anemia and then she had hypersplenism. So this disease was not diagnosed earlier. Next. See, this is the papillary cytoplasm. Next. Look at these two cells. Is there any difference? Difference? Yeah. So the cytoplasm here is more blue compared to the cytoplasm here. So what are these cells? They may look like Gaucher cells. Ceblohistiocytes. Ceblohistiocytes. Next. So you need to know about the pseudogaucher cells and the Gaucher cells. I'll just show you a table which differentiates the two. Next. So this is how do you identify the pseudogaucher cells? They have the bluish color, and you can see them in the concentric blue lamellae which fill the cytoplasm. They say it gives an onion skin appearance to the cell, and the histiocytes they have a lot of cellular debris and sometimes lipids also. Increased cell turnover. So you see them in many conditions like next. Yeah, there's spheroid also. So you see them in many conditions. There is another slide next. Previous. Yeah. So these are the conditions: CML, AML, ITP, myeloma, then Hodgkin's. So they do not have the typical appearance, and of course we can go for special stains and go for the history. So PAS stain in these is negative, whereas Gaucher cells we say there PAS positive. Spheroid histiocytes. Then Niemann-Pick cells need to be differentiated from Gaucher cells. Next. How does Niemann-Pick cell differ from the Gaucher cell? We have seen the Gaucher cells of the bone marrow now. So here, they vacuolated. They have multiple vacuoles, they vacuolated cytoplasm, and the size is slightly smaller than that of the Gaucher cells. And so you may use fat stains like Sudan black and oil red to demonstrate these cells. And PAS stain, even if they take, they're lightly positive. Next. What is this now? This organ is spleen. You can see the white pulp, malpighian corpuscle with the peripheral arteriole, and these are the cells which are infiltrated, so which have the vacuolated appearance in contrast to the wrinkled tissue paper with striated cytoplasm that you saw in the Gauchers. Next. Yeah, this is only high power to show how these cells differ in appearance from that of Gaucher cell. Next. Yeah. This is the difference. So what is the enzyme defect in Gauchers and what is the enzyme defect in Niemann-Pick? Storage product, glucocerebrosidase, sphingomyelin. So other organs which are involved, so liver, adrenals, lung, bone, CNS in infantile form. So here it's brain, liver, lungs and bone marrow. Then hematoxylin, it's wrinkled silk or wrinkled tissue. Right, Jim said this is colorless, this could take, but vacuolation is very important. So PAS positive, this is variably PAS positive. So PAS with the diastase, this is positive, whereas because it's glucocerebrosidase. And another stain, as you do a Pearl's stain, so it is positive for Gaucher's disease, whereas here it is negative. So then, of course, electron microscopy, you can see the characteristic features. Next. Yeah. What is this? Early Mayer flask. I remember my teacher who used to ask me a question as to why this has a long neck. Two of my teachers, when I was doing PCP, it was Dr. Krishnamurthy in BMC. I was bowing with him, who taught me all the clinical pathology and the techniques, histopathology and all that. Then histopathology proper, Dr. H.R. Chandrasekhar in HMMC, two great teachers. If I've learned anything, it is from these two teachers. So he used to ask me a question as to why this is. So we used to have a lot of LMAD class with even the long neck. Why? The volumetric, right? Volumetric flask. So he used to tell me like, this is not just to hold it. So the volume, what happens once it is heated, the fluids are heated? The expansion, right? So he used to go to that level to say like, fluids expand on heat. So that heat probably which could be transmitted, you may feel it as so silly and all that. But when it goes to real research purpose, that definitely contributes. So that's why they have a long neck, he used to say. I just put this early Mayer flask here to show you that because we say X-ray, typical appearance of X-ray of long bones and Gaucher is early Mayer flask deformity. Next. Yeah. We will move on to the next slide. Next, third one. We come here last. Yeah. Anybody who saw this Slide. There's a young male swelling in the neck. So, the approach. If you're a surgeon, what do you do? So, if you're a physician, what do you do? Young male swelling in the neck. Surgeon?
FNAC.
Surgeon FNAC. Okay? Examination? Examination? Surgeon concentrates on? Locally. His concentration is on the swelling. Physician? General physical examination. This is how, see, the approach varies, right? So, my professor in BMC used to tell me, when we are posted as students in surgery, he used to tell me, don't pick any case with a lump, bump and hump is important. As you just jump, to see a case where obvious swelling is there. He used to tell me, every patient teaches you. So, this is how a surgeon looks probably at the lesion. What is it? Very bad picture, sorry. What is it? Lymph node, agreed. Lymph node? Yes. 3, nodal fat, capsule. And what do we see here? 1, 2 follicles at least. Yeah. With a prominent germinal center. Yeah. Just a closer look at the follicles. Yes. Now, very difficult. It's just a low power. Yeah, we are convinced it is lymph node by the low power appearance. Now, that was scanner. This is low power. You are just looking at the lymph node. Lymph node pathology is easy. So lymph node is a graveyard for the pathologist. Very, very difficult. The two, the cases which Dr. Hazarika presented. Yeah, if you're working, if you're in an onco institute, yes, that's easy for you because you go with all the panels. Not for general pathologists like us who are in the periphery where we do not get all these panels to be done. And even if you want to do academically, it becomes very difficult because the private management will question you if you're spending, and our patients cannot afford. Patients who come to us, they cannot afford. Yeah. Next, anything, any observation here?
Kind of things, maybe statistic pattern of working.
Very good, very good. So then, I just wanted you to observe here. There's something, the histiocyte kind of, yeah. Is it starry sky? Where do we see starry sky? Where? In Burkitt's lymphoma. Which part of, architecturally, where are they present? Within the follicles? Yeah? Yes? Yeah, you had an answer. Within the follicles, yes. So where are you seeing these cells? Yeah. Very good, paracortical. Yes. This looks like there's necrosis also. There's an area of necrosis. This is, okay. The follicle which you saw. Looks benign or malignant? Benign, yeah, it's a hyperplastic lymphoid follicle. Next. Not very clear, and we'll go there. Yes. This is what you said. Some histiocyte-like cells which you see. So follicles in between. Slightly higher power of these are the histiocytes. The sinuses, sinus histiocytosis, are they within the sinuses? Do you agree they are histiocytes? Yes? Next. Look at these cells. The outline, the nucleus. There are varying sizes. Yes, they are histiocytes. Next. We'll go there to the JPEG. Yeah, we have seen this. This is only to show you a better morphology. Can you appreciate them now? Observation. You need to look at these histiocytes. They're telling you that I am so familiar. You keep seeing me somewhere routinely. The epithelioid cells. Where are epithelioid cells? This one? No, these are macrophages, right? This is an epithelioid cell. Okay, look at these cells which are looking at you. Then we look at the epithelioid cells. These are macrophages. You agree they're macrophages? Any other observation? You observed macrophage in Gaucher's disease. You observed a macrophage in Niemann-Pick's disease. You observed macrophage in C-blue or pseudo-Gaucher's. Why don't you observe this macrophage? Yeah, excellent. They have something inside. What do they have? They have macrophage with mucin. Macrophage, they're looking like symmetry. Muciphages? Muciphages? Yeah. This was also associated. Somebody said there were these cells also. Look at this. Look at these cells. Look at this. Yeah. Look at this. They were associated such cells also. What is this? Giant. What type of giant cell here it is? Yeah? Typically, look at this nucleus. Epithelioid. Okay? We look at the images of the histiocytes again.
Can we get Zelenstein for this one?
Why Zelenstein?
Maybe atypical mycobacteria.
Maybe atypical. Yeah, he thinks of atypical mycobacteria.
Cell exclusion which is looking clear in HND, maybe it's highlighted in Zelenstein.
Okay, you mean to say which type of atypical mycobacterium is just with this appearance? MAC, okay. But you don't see cell. I'm telling you, these cells you're very, very familiar with. The cell is telling you, I meet you every day or quite often. Though some centers are closed, you know. You keep seeing me, but I'm in a different place now. Yeah. Leprosy. And they're not lepra cells. Don't they have typical morphology? That eosinophilic, it's appearing slightly bluish, the globi which are there within the cells. The degenerated bacteria which give rise to that appearance. Pink material that you can see within the lymphocytes, but within the macrophages. So the morphology tells you, but I agree, you need to do a Zaden. When you said Zaden, probably looking at the macrophage, I thought you had that in mind. Yes, so these macrophages, they have the typical morphology of lepra cell. I told you this patient had gone to a surgeon. The surgeon happily excised the lymph node and sent it. Now how do we proceed further? Now I have seen this morphologically, and what do I do next? Yeah? So the sections, the tissue is with me. So I have something that is being done in the laboratory, then go and examine the patient. So the patient typically had the skin lesions. And there were areas of necrosis. There are a lot of case reports that say that tuberculosis and leprosy could be together, seen in a lymph node. Or it could be borderline where even the epithelioid cells could be there. So we did a Zaden stain. So what is that Zaden stain we should do here now? 5-ferro modified, Wade 5-ferro. What is that modification? You need to use less acid. Then, what is it modification? First step. Yeah, we are heating this smear, that's all, not the section. Okay, first step is you have to bring the sections to water. What do you do after you take the section? To deparaffinize. So what is the first step for Wade 5-ferro modified? Very good. You have to use peanut oil mixed with xylene for deparaffinization. Why? Because that is supposed to restore the acid fastness of the bacilli. Then use lesser concentration. You may just go with 2% sulfuric acid for this. Then, after you do everything, please don't go to alcohol for dehydration. Even when you do a smear or tissue sections for skin sections for leprobacilli, because AFP we say is the Mycobacterium tuberculosis AFP, it is acid and alcohol fast. This is just acid fast, but alcohol may remove the stain that the bacilli have taken. Next. We'll go back to the PPT. I'll just show you these sections are positive. The cells showed positivity. There were bacteria, but it was quite difficult for us. And you see these viable, degenerated ones. And whenever we have to observe for these bacilli, you have to look at the macrophages which are at the subcapsular zone. You can see there. Yeah. So lymph node lesion shows spectrum of changes. It could be lepromatosis to tuberculoid. So in order the lymph nodes are, so you know which are the lymph nodes, and you have to always examine the patient thoroughly. Next. Though leprosodiums are closed there with us, so you can see in our dermatology clinic, new cases of leprosy are being identified. We see so many students, teenagers who come with skin manifestations. So the paracardial areas, that is what's enlarged lymph node, depleted of lymphocytes, and they are replaced by sheets of histiocytes and lepra cells, the typical morphologies. Then germinal centers are prominent. So we could see 1 or 2 follicles with prominent germinal centers. Plasma cells, I think I didn't show you, there are plenty of plasma cells. Next. Yeah, early lesions, you may see just 1 or 2 bacilli. Advanced masses of AFP, that is globi. And they could be microglobi or larger globi. Next. 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 Yeah. As you said, Mycobacterium avium intracellular. Yes, next. Yeah. So this is what you see the cells. This is started with bacteria AFP. The next slide. The last slide is only for just identification. Before this, just see this. Yeah, this I said is for morphology, morphological appreciation. You see the luminal structure? It has something. Move. What does it contain? Maybe some cells which are looking like neutrophils. Look, next. 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 Yeah. This is whatever luminal structure we saw. There is no lining. Only focally we could see some epithelium. Next. Look at this. Whatever was there in the lumen. Can you appreciate the neutrophils? What do you appreciate? What do you see? Yeah? How about the cells? It's like? Sperm, yeah. Yes, I just gave you only to observe the sperm heads here. This is sperm granuloma. This is the lumen. So this is post vasectomy where there is a nodule. Then leakage of the sperms into, or leakage of the sperms which are given rise to sperm granulomas. This is the lumen. I'll just show you one more section. Maybe we can move. So this is in the wall. Can you appreciate the sperm heads? In the wall? Yes. The smooth muscle. And look at this. So sperm granuloma is another slide that you could get in the examination. Next. Go to PPT. What is this? Yes, sir. Any structure you can identify? Epicardialis, okay. Okay, that was sperm granuloma. This is one thing you need to know about vesitis nodosa. After vasectomy or vasostomy, supine end of transected vas deferens contains an nodule, and many times it typically mimics any lesion that is similar in the fallopian tube. Salpingitis systemica nodosa. Okay, now for you to identify this. What is it? What is it? Where is the suture material? They use brown suture? Hair. So this is hair shaft which is giving rise to Janssen reaction. See? Very clear. Next. Yes? Cholesterol reacts with Janssen reaction. Next. Gout, uric acid. Yes. Staph is keratin. Tell me 3 conditions where keratin can give rise to foreign body granuloma. Lesions with keratin granuloma. Epidermolysis. Venopharyngoma. Common. Squamous carcinoma. Any next tumor? Benign pilomatricoma. Yes. Why did I put all these pictures at the sperm granuloma? Why did I show you all this? It's not foreign. Native to the tissue, but when it just goes out, this is the reaction. There are some things which are native to the body, but at the normal size, they are recognized as foreign body, and the reaction. Next. Yeah, the last slide is only slide for diagnosis. Nowadays, you hardly get to see this. This was a slide for me when I was doing my MBBS. Then I have seen a lot of specimens, and nowadays you do not get to see this specimen. See how the therapy has improved, and you do not get to see them. Yeah. It's only necrotic tissue. It's an ulcer. Next. This is stomach. Okay, there's an ulcer. Next. See the zones. So the necrotic zone, this is the exudate, typically with fibrinous material. Then the granulation tissue and cicatrization or fibrosis. So these are typical Ashkenazi zones with Anderson, when we were reading this to describe. So nowadays, do you see resected specimens of stomach? No, hardly. Only if by chance there is perforation, they operate or they remove. Otherwise, I've seen a lot of nice benign gastric ulcers. Next. Yeah, this is only to see the pictures again. So look at that granulation. This is the exudate, then the granulation tissue. This is the exudate again. This is sclerosis or fibrosis. So this is about chronic gastric ulcer. I just, who is very experienced, he may get a slide for you. There are professors up to the age of 65 now, they can be examiners, not after 70 years they qualify to be PG teachers. That was the only interest for me to have put this slide. So thanks a lot. These are, I think you may encounter it in your practice. I've just exceeded my time. Very sorry, Koustub, and I don't know, I can't just be very short and sweet, and I think I tried a lot, but I have something to carry home message for all of you, I think. Okay, thanks a lot.